So, very good afternoon. We are starting our clinic now. So, a very warm welcome to today's NITRD CTD NTF Difficult to Treat TB clinic. On behalf of NITRD, it is my privilege to welcome our DDG Madam, Dr. Urvashi Singh Ma'am, directors and teams from NIRT and NTI, all the state TB officers, directors of STDCs, faculty of medical colleges, district TB officers, medical officers, and others. A warm welcome. And a very warm welcome to Dr. Behra sir and Dr. Bharadwaj sir for joining us. Uh, Today, we all know we have a very big festival in the country, so maybe we have limited attendance, but I hope everybody enjoys the festival. So, introducing the faculty from NITRD, I am Dr. Singla, Nodal Officer, DRTB Center at NITRD. On my right is Dr. Rupak Singla, who is a consultant in Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is a pulmonologist at NITRD. I would now like to welcome our director, Dr. Upasna Agarwal. I now request her to give her introductory remarks. Over to Dr. Upasna.
Ma'am, can you hear us?
Yeah, you're clear.
Yeah. So, hi everyone. And I want to congratulate the team once again and all the audience gathered here for for another important session of Difficult to Treat TB Clinic. I know this clinic has been running very well for the past few years and it has contributed a lot to the knowledge about how to treat TB. Is DDG ma'am also there? I
Yes.
would like I would
Madam,
like
yeah.
I would like to welcome DDG ma'am, Professor Urvashi, and also all the esteemed speaker and all the esteemed audience here. And with these few words, I hand over the mic back to the ECHO team.
Thank you, Dr. Upasna. Now I would like to welcome our DDG Madam, Dr. Urvashi Singh Ma'am. Ma'am takes a very keen interest in our clinic and she is always there. We always look forward to her guidance in these clinics. I request her to give her address to all of us. Dr. Urvashi Ma'am.
Good afternoon to everyone. Namaskar. The spirit of this clinic has always been very encouraging for everybody who joins. So to begin with, I must thank the team under Director NITRD, who has consistently contributed, medical officers who join, the STOs, the DTOs who are, who can make themselves available for gaining, knowledge during these CMEs. So thank you, the team led by Dr. Neeta Singla for the DRTB clinic and led by Dr. Sangeeta Sharma for the pediatric echo clinic. So these efforts have gone in a long way, not only to deal with difficult cases, but also to communicate regarding the program guidelines, which we keep updating as and when the scientific evidence gets accumulated. Several changes, we keep bringing them in. So today's case especially is of interest to all of us because this is an area where we feel more knowledge needs to be disseminated that TB can co-occur with the cancer, the basic premise being that the drugs meant for treating, for example, if it is a pulmonary carcinoma or other sites, can themselves, in addition to the disease leading to immune compromised status, the drugs could also have some effect. And often the drug regimen may contain such drugs which may lead to the immune response being weaker, which can in turn reactivate TB. So I think the message for today is that the co-occurrence of the two major illnesses should never be ignored and ascertained, in fact, because TB is something which can be cured by a very defined regimen, though in immune compromised patients, sometimes a longer therapy may be required, which I'm sure the team of experts can deal with. But this message has to go far and wide because often when we get one diagnosis, we sometimes may not look for another diagnosis which may coexist. And while we are treating for one, the other equally severe condition may worsen. Hence, I think the message today is very, very important for us to actually look for TB while we are treating the cancerous condition. So thank you for choosing this topic, and thank you to the team who will be presenting today. Dr. Rishi from UP is also here, and of course the team is here. And I would also like to pay my regards to our senior experts who have spared the time to join. Dr. Behra sir, Dr. Bharadwaj sir, thank you for joining. And
Thank you, madam. Thank you.
we look forward to your kind guidance, sir. Thank you again, Dr. Neeta, Dr. Rupat Singla. And please carry on, and we can all pitch in again with our additional points. Thank you.
Thank you, ma'am. Thank you for briefing us so nicely. Now we go ahead with our clinic. So in our series of different states discussing their cases, today's case is from state of Uttar Pradesh. The case presentation is by Dr. Ashwini Kumar Mishra. He is Associate Professor and Head Department of Respiratory Medicine at BRD Medical College, Gorakhpur, and he is also the Vice Chair of UPSTF. The state expert will be Dr. Rishi Kumar Saxena, who is the Deputy State TB Officer, and he is the Joint Director TB, and he is a chest specialist with honors at Directorate Swasthya Bhavan, Lucknow. And our national expert is Professor Dr. Digambar Behra sir, who is a Padma Shri awardee, and he is Professor Emeritus, Professor of Respiratory and Critical Care Medicine at PGI. The clinic expert will be Dr. Rupat Singla, who is consultant in Department of TB and Chest at NITRD. So I thank you all, and I request Dr. Ashwini to go ahead with his presentation.
Good afternoon to everyone, respected seniors, Behra sir, Bharadwaj sir, Singla sir, and all my respected teachers. I bow to them, and we start this clinic today, and I am thankful to NITRD to provide me a chance to present this. So it would have been very easy for me to. Am I audible, ma'am?
Loud and clear, Dr. Ashwini, please carry on.
Of my senior resident program, but I chose myself to present this because I want a message to go deeper in our faculty, in our NTP program colleagues, that every one of us should be very sincere and should consider our first responsibility to treat TB patients. So again, I am thankful to NITRD. So I am starting my case. So this is a patient of pulmonary tuberculosis, and we will see in the frequent slides how the story goes on. But
Sorry to interrupt, Dr. Ashwini. Dr. Ashwini, आपका PPT नहीं दिख रहा है हमको.
1 minute.
हाँ, please. तो वो दोबारा आपको लगाना पड़ेगा. आपने पहले लगाया था.
Yes, 1 minute.
कोई बात नहीं.
Is it visible now, ma'am?
Yeah. Nice.
So we have this case of a pulmonary tuberculosis patient with lung cancer, and we will see in the frequent slide how the story goes on. But before starting the slides, I will just take 1 minute to say that most of the time we just think that if a patient
Dr. Ashwini, sorry to interrupt, Dr. Ashwini.
He or she might be only suffering from drug resistance, or there must be some. Yes.
वो बीच में ना आपका आवाज इंटरप्ट हो रहा था, तो हम ये सजेस्ट करते हैं कि आप थोड़ी देर अपना वीडियो ऑफ कर दीजिए जब तक प्रेजेंटेशन चल रहा है आपका, तो वो आपकी आवाज क्लियर हो जाएगी.
Okay, now it's okay, ma'am?
Yeah. Okay. Thank you. Yeah, the voice is now clear. हाँ आ रही है सर, क्लियर है आवाज.
ठीक है मैम. So this patient is a case of TB with lung cancer, and we will see how the story goes on in our coming slides. So first, just I want to say that in the most of times when our TB patient doesn't respond to treatment, we just think that either the patient might be suffering from drug resistance or there must be some compliance issues. But we most of times miss the comorbidities and the other factors which may be responsible for not up to the mark response of the patient, what we are expecting from the patient, how should the patient go. So we will try to focus this thing in today's clinic. So this is a 47 years male patient presented to us with low-grade fever for 1 month.
डॉक्टर साहब स्लाइड नहीं आ रही है.
Sputum and streaky hemoptysis for 1 month. Pain in the chest and breathlessness for 1 month. Sir? Sir?
Okay. Go ahead.
Hello?
Go ahead. No, go ahead.
So this is 47 years old male and presented with all histories of from 1 month of low-grade fever, cough, sputum, streaky hemoptysis, and chest pain. He was not having any past history of VTT or contact with patients with TB. And their personal history, the significant personal history is that the patient has been a smoker for 9 years. And at least he was having 20 to 22 packs per year. So this was the X-ray test of the patient when he presented to the clinic, to the hospital. And when we subjected the patient for microscopic examination, we found that the patient is having 1+ smear positive. In CBNAT, there was MTB detected and rifampicin resistance was not detected. Patient was diagnosed as a case of pulmonary TB with rifampicin sensitive by the private practitioner, and ATT was started on the weight band of 55 kg. Was started at isoniazid 300, rifampicin 600, ethambutol 1000, and paraginamide 1500 from a private practice. But the patient did not improve despite 1.5 months of regular ATT. Pain in the chest and cough persisted. X-ray showed increase in lung infiltrates, mild hemoptysis increased, and the patient started having weight loss also, and he lost approximately 3 kgs in last 1.5 months. So this was the X-ray test at the beginning, and this was the X-ray test after 1.5 months of PT, so that we can see that been a no response, and in fact the X-ray has deteriorated. And again, it subjected their microscopy, and in CBNet also there was no MTB detected. So the treating physician amikacin and levofloxacin along with RHEZ to the patient. So patient was added amikacin and levofloxacin, and then he was referred to the nodal TRTB center because of the non-response to the treatment. So when he came, so we saw that what the X-ray chest was at the beginning, and X-ray chest after 1.5 months of ATT, we saw that there was no good response, and the patient was not having proper response to treatment. So what we found that in the X-ray, there was a right paratracheal opacity also. There was a right paratracheal opacity, which may be something, either lymph node or something. We thought that the patient is a case of pulmonary TB. So he might also be having some mediastinal lymph nodes also, what we were suspecting of that, or the patient might be suffering from some other comorbidities also. So we continued the treatment, and after in the whole process, it became 2.5 months. And in the 2.5 months of treatment, we again saw that the X-ray is not improving, and the shadows have become more progressive and have involved whole of the lung fields. So we decided that the patient may be suffering from some dual pathology. And again, after confirming that the patient is not having TB, we subjected the sputum for cytology also, which the report showed that the malignant cells may be seen. There was a malignant cell seen, and there was doubt of malignant cells in the sputum. So we did a CT scan, and what we found in CT scan that there was a mass in the right paratracheal region, and there was multiple secondaries in both lungs. There was multiple secondaries in bilateral lungs. So bronchoscopy was done, and transbronchial lung biopsy and bronchial aspirate showed that their patient is suffering from alveolar cell carcinoma. So now the patient refused any treatment because he said that no, once I have developed TB, all people they said that you have got TB. I took TB treatment also. Now that you are telling that I have cancer, and now I have to take this treatment also, and so he refused any treatment, and the patient died within the next 2 weeks. So now this is the case which shows that dual pathologies may be present in the same patient, and we finally diagnosed that the patient has both their thing, that he's also suffering from bronchogenic carcinoma and pulmonary TB. So we come to discuss on this patient about what are the reasons for delay in the diagnosis. Is there any role of CT scan in pulmonary tuberculosis? And what are why the comorbidities to be issued? What comorbidities should always be issued? When disease may coexist or not, and when we should suspect that. And we should we'll also discuss, or we'll also try to ask, is a non-response can only be drug resistant, or there could be other reasons also for non-responding to the ATT. And when we think of lung cancer, we should have we'll discuss about how should be a complete history taking, and what's the mode of diagnosis, and what signs and symptoms we should be aware of, which may suggest that the patient may be also having any type of malignancy also. So the case is open for discussion now. Thank you.
Thank you, sir. It's an excellent presentation. We open house for any questions on the history or diagnosis of this patient.
Dr. Ashwini, I have a question. This patient was treated for pulmonary TB as he was diagnosed on TB-NAT, and later then he didn't respond. It was at the end of the treatment, or did we follow the patient in between, or did he initially respond to the treatment, or the symptoms resolved in between, or was like aggravated?
Ma'am, the patient was first taking treatment from outside private practice. Then he came to us, and when he came to us, then at that point of time, we saw that in the 2 X-rays which the private practitioner had did at the follow-up, the patient was not responding particular to treatment.
That was
properly. So we, at that time, all the doubts raised, and we further proceeded forward.
He presented to you at the end of treatment after completing 6 months.
No, the treatment cannot be get completed. I mean, 3 to 4 months, 3 months, the diagnosis changed towards the bronchogenic carcinoma, and the patient refused treatment, the patient died.
Any other questions?
Dr. Ashwini, as I believe from the history, patient had taken first-line drugs for 1.5 months. Patient did not improve. The X-ray shadows increased. Then the treating physician added injection and fluoroquinolone for about a month. Still patient was not improving. That was the point patient came to you. Is that correct? That is the understanding from the presentation.
Yeah, that was the point. The patient was because of not responding to treatment and worsening symptoms like chest pain, hemoptysis, fever, weight loss. The fever was not particularly more there. The weight loss and hemoptysis triggering that he started to having hemoptysis. That got him to consult, take a secondary opinion. And the physician also thought that after giving 4 drugs and again adding 2 drugs, also the patient not responding. So the patient do not.
By the time you received the patient had taken 1.5 months first line and 1 month of first line plus injection and fluoroquinolone.
2 months to 2.5 months the patient is taking treatment. And when we saw the X-ray, we thought that there was doubt that the patient might be having some other thing also. When we saw the mediastinum in the X-ray, it was there is some doubt of mediastinal lymph node or mediastinal lesion which was present. That was present from the starting itself, but when with the time that we it's very easy to anything retrospectively. So when we have seen that already the patient has taken treatment and we retrospectively analyze the X-ray.
So any comorbidities, diabetic or this patient?
The only thing he was having is he was very good, very smoker. Otherwise, there was no other thing which was significant.
Right.
You said his gene expert was positive. It was done.
Yes, ma'am. Yes, sir. Gene expert was firstly positive with rifampicin sensitive. In the initial state, the prior practitioner ने कराया था, उसमें सर था पॉजिटिव भी था, डिटेक्टेड भी था, AFB भी पॉजिटिव था. He was a confirmed case of pulmonary TB, microbiologically confirmed case of pulmonary TB.
Okay.
अश्विनी पैथोलॉजिस्ट से आप शेयर कर सकते हो कि alveolar cell carcinoma is no longer the term to be used. Whosoever has reported.
हाँ sir, I will talk to the pathologist that the reporting system has changed. I agree to that not alveolar cell carcinoma is out, not the molecular system.
Dr. Rishi, can we have your comments as state expert?
Yeah, ma'am. Okay. I'm sharing my screen, ma'am. Just a minute. Yes. Share screen. Is my screen visible, ma'am?
Yes, sir. It is. Slideshow पे कर दीजिए.
So since we have discussed this case and we came to know that patient was initially diagnosed with
slide ये last slide दिखा रहा है.
Okay, ma'am. Okay, just a minute.
Slideshow पे भी कर दीजिए.
अब मैडम क्लियर है?
Yes, sir.
Clear, ma'am?
हाँ, slide show पे नहीं आया सर अभी.
Okay, madam, slide show pe I have done, madam, actually a slide show pe. Just a minute. You are sharing screen. Stop share. Screen share. Share. Now it is clear, ma'am?
Yes, sir.
Okay.
पर अभी वो slide show अभी भी नहीं आया सर.
Just a minute.
Can you do it? Abhi it's okay. Yeah.
Okay. Thank you. So now, as we have listened this case, that the patient initially was having pulmonary TB, and when the treatment started, the patient conditions did not improve but got deteriorated. So, and the one thing which we had a clue was the patient was a smoker also. So on these lines, we see that first we have to understand both the things, the pulmonary TB and the lung cancer. A missed or wrong diagnosis of lung cancer by clinician or a general practitioner can lead to delays in treatment, wrong diagnosis, wrong treatment, or no treatment at all. Now, in our country, the main delay is mainly accounted for by patients' ignorance in reporting to general practitioners, because lung cancer symptoms definitely are not improvement. Misinterpretation of chest radiograph findings, starting antitubercular treatment for suspicious opacities on chest radiographs without proper evaluation, using appropriate investigative modalities like CT scan, sputum cytology, and bronchoscopy. Besides this, the high cost and inaccessibility of the diagnostic investigations such as CT scan and bronchoscopy may contribute to their inadequate utilization in early phases also. In tertiary centers, the waiting period for these investigations is often unacceptably long, and this adds to further delay. And many times, clinicians start ATT without detailed investigations. Now, here it is a evidence-based fact that there is a relationship between tuberculosis and lung cancer. There is an inhibition of the immune cells and cytokinins from the MTB, which leads to reactive oxygen species, which causes further DNA damage and inhibits apoptosis, which releases CRP, C-reactive proteins, and there is also overexpression of the cyclooxygenase 2 part, which promotes metastasis. And all this leads to aberrant expression of immunity receptors, which leads to lung cancer part. Now, as we have already know that there are 10 symptoms of pulmonary TB. We have been listening now in our 100 days campaign also. Now here you are seeing that out of 10 symptoms, 7 symptoms of the same are also present in the lung cancer, which we have to really see now. The features which differentiate it from lung cancer and pulmonary tuberculosis are fever, night sweat and fatigue, which happens mostly in pulmonary tuberculosis, and generalized weakness, right-sided abdominal pain, blood clots all over the body, which usually happens in the lung cancer. But there are differences which can be viewed from pulmonary tuberculosis and lung cancer, which is regarding age. In pulmonary tuberculosis, we know that it is a bread earning age from 15 to 45 years, and lung cancer is usually a middle or elderly age. Previously, now it is also coming in the young patients also. Smoking history, it may be present or absent in pulmonary tuberculosis, and lung cancer, it is usually present. Fever, persistic hai, low grade, evening rise are non-specific, mostly in the lung cancer. Weight loss is significantly slowly in pulmonary tuberculosis, but sudden weight loss occurs in the lung cancer. Hemoptysis is early feature in pulmonary tuberculosis, but is a late feature in lung cancer. Breathlessness, mild and specific in tuberculosis, vague and dull in lung cancer. Chest pain, present or absent in tuberculosis, usually present and severe in lung cancer. Clubbing, present or absent, and it is usually present in lung cancer. Then coming to lymph nodes. In pulmonary TB, we have seen that cervical lymph nodes, for example, it is firm, matted, painless, non-tender, and it may turn in cold abscess in future course. But in lung abscess, in lung cancer, it is present hard, single. If multiple, then it is usually non-matted. Tenderness over chest, it is usually absent in pulmonary tuberculosis. It is present in case of chest wall involvement. Hoarseness, it is rare in tuberculosis, but if metastasis or mass involvement is there regarding and is invading left recurrent laryngeal nerve, then the patient may have a hoarseness of voice, which may indicate that patient might be having some other pathology apart from pulmonary tuberculosis. Backache. Now, backache, if associated with port spine, may be present, but if metastasis also, it may be present. In paralysis, also, if it is associated with port spine, and also metastasis if present in the spine in case of lung cancer. Now, coming on to the radiology part. In chest X-ray, pulmonary tuberculosis usually appears in the upper zones mainly because the bronchus is on the right side and all these things are there. But in lung cancer, there is no such anatomical predilection for these opacities. Regarding common radiological shadows, which we see in pulmonary tuberculosis are infiltrates, lymphadenopathy, biliary, pulmonary effusion, and cavities. And in lung cancer, we have masses, hilar prominence, pulmonary nodule, widening of the mediastinum, total or partial atelectasis of a segment, lobe or lung, unresolving consolidation, cavitation and pleural effusion is also here. Elevated diaphragm may be there, and at times rib erosion is also there. Response to ATT, definitely it is good in pulmonary tuberculosis, and if we are seeing that it is condition is deteriorating and there is no response, then we have to think of other DD also. Chest, thorax, infiltrates, cavities, and lymph nodes are seen, and also mass, eccentric cavity, and lymph nodes are also seen in this lung cancer. So now coming to diagnosis. The diagnosis of TB and lung cancer can be difficult as symptoms of both diseases are similar, we all know. Currently, as the incidence of tuberculosis in elderly tends to increase due to increase in immunocompromised status like diabetes, HIV, and lung cancer is also not rare in youth. So patient's age is no more a good reference in DD now. However, diagnosis of lung cancer in patients with tuberculosis with or without residual effects of TB possess some peculiarities. This depends on the variety of clinical symptoms, clinical codes, site of cancer. In case of ineffective specific treatment of tuberculosis, existence of lung cancer should be presumed, as was seen in this case also. Then proper clinical examination and investigative workup is needed to reach the correct diagnosis. So the take-home message is that the coexistence of both diseases in the same patients may delay in diagnosis. Number one, patients with lung cancer are vulnerable to develop active TB because of immune suppression induced by the use of intensive treatment modalities such as aggressive chemotherapy, radiotherapy, and nutrition. Because of simpler treatment regimen for latent TB compared to active TB, preventive chemotherapy of latent TB may be preferred in lung cancer also, which NTP program is giving to such patients as they are already been included in the vulnerable group as we have seen in the 100 days campaign. as DDG Madam also has highlighted about this in this starting brief session. Now, anti-cancer chemotherapy is not an obstacle of treating tuberculosis. This information will definitely help physicians to make clinical management decisions for patients with coexisting lung cancer and active tuberculosis. Now, these are the 5 patients, which 2 patients I have personally contacted them, and 3 patients, unfortunately, they were died. So I contact from the relatives. And here you are seeing that most of them had cancer. Lung was also involved in these cases. And in treatment, 3 patients, they have died. Maybe the delayed treatment was there of lung cancer, or the treatment TB treatment was there, as happened in this case also. And the 2 treatment, though there are 2 patients also, they are currently on both the regimens. They're having TB treatment also, as well as the treatment for lung cancer also. This is all which I want to spread the message to all this participants that both are also there. And if the disease of either disease is not improving during the treatment, we have to consider other details also. Thank you.
Thank you, Dr. Rishi. That was an excellent presentation. Are there any questions and queries to Dr. Rishi? If there are no questions, I would request Dr. Behra.
Ma'am, I have a question to Rishi, sir.
Yeah.
Sure.
Sir, what is your opinion that if we diagnose both disease in a patient,
yes,
and we diagnose a patient with an end stage lung cancer or any other cancer, so when the decision to treat should be taken?
See, it depends.
Either in that case, it's with such extensive pulmonary TB and extensive lung meds, either giving treatment of lung cancer to that patient is going to help him, or we are just increasing his problem by treating him.
No, so see, starting we have to give both the treatment, because we have to also see the other things which are happening in both, like breathlessness might be there also if both the things are there. The fever might be having also. So these things we have to treat simultaneously. Along with, we have to also give the after correct biopsy of the lung cancer, whether it is adenocarcinoma, squamous cell carcinoma, we can give those treatment also along with the TB, which we have taken from the sputum or other diagnosis also. Both the treatment can be simultaneously started. As we at present also in our UP patients, 2 patients are there on treatment. One is having breast cancer and one is having Burkitt's lymphoma. He's a child, and both are having doing on treatment of both the lung cancer also and pulmonary tuberculosis also. So we have to think of the both, sir.
Thank you, sir. Thank you. I have also got 2 publications on the same topic. One of my patient was having schwannoma with pulmonary TB, that published in BMJ, and my patient is having carcinoma cheek with TB, and that also published in Lung India.
Oh, great, congrats. Yeah, carcinoma, this recurrent laryngeal will present in the wholeness of eyes. Yeah, cheek, okay, yeah.
Dr. Behra, sir.
Yes. So thank you, Nita, and a very good afternoon to everybody. It's a very nice case presentation and good discussion. I'll just like to highlight certain points which are already been told. You see, both TB and lung cancer, the possibilities can be either way. Either there may be a wrong diagnosis, maybe lung cancer misdiagnosed as TB, or TB misdiagnosed as lung cancer, clinically, of course. And then number 2, there is a term called the scar carcinoma. I think everybody knows about that. And third thing is how to manage and how to know when both things are occurring together, or what we call the concurrent TB and cancer. So if, as very rightly said, what actually went wrong in this case? Did we miss the diagnosis? Was it a concurrent cancer and TB? Yes, of course, there is no doubt there was a smear was positive. In addition to that, he had also gene export, or the NAT test was also positive. So obviously, the diagnosis of TB, I think, is not in doubt. The only issue, if you see the chest X-ray, of course, it was a projection. I am not sure. You can always see in the upper part, the right paratracheal region, there was always a widening. So that was one clue. Whoever has reviewed the chest X-ray, he or she should have been little careful. Again, let me tell you, it is a retrospective thinking. It is easier for now to tell, yes, there is something, some prominence there. It might have been missed by anybody also. But I think two or three other things which we missed. Once it is a rifampicin sensitive TB, the patient is getting all four treatment and he is taking the drugs diligently, then he should have started improving, right? He should not, his chest pain should have improved, although all these symptoms can occur in both cases. His weight, he should have started gaining weight. So therefore, I think what is to be highlighted is the, even if giving ATT to a patient, and we have to follow up the patient and see his clinical improvement, clinical condition. So then the doubt should have been raised when he or she is not improving. Then the various other symptoms, very rightly, he pointed out how to, although, but only thing we have to be very careful that some of these symptoms, as he said, out of 10, 7 are common to both lung cancer and TB. These are only relative terms. But certain signs, like as he told, clubbing is unusual in TB unless it is very extensive cavitating form of TB or post-TB bronchiectasis. Clubbing is not common. SBC is not common. Hemorrhagic effusion is not common. Hoarseness of voice is not common in case of TB. But again, I emphasize that these are only relative points. A particular case may be different from the entire series. Then the second point, once the patient is not improving, then we always think that, okay, he's not responding means you add something which is, again, I'm sure Dr. Singla is going to comment about that. I don't know why instead of adding streptomycin and fluoroquinolone, so he should have investigated in a little different way. That is what another mistake the private practitioner did. And the third point is, again, I will emphasize about the interpretation of chest X-rays. When the patient is not improving, his follow-up should have been little more close follow-up. And then he should, an early CT scan should have been done. And of course, by the time he came to the medical college, so they did the whatever thing they will do. The chest X-ray, even simple chest X-ray, if you see, the shadows are increasing. They're all alveolar shadows, both sides. They're very typical of so-called bronchoalveolar cell carcinoma. Although we don't no more use that type of terminology now, but still, as a clinician, we still, whenever the presence is like that, pneumonia like consolidation, and there is a prominence in the paratracheal region, calling it bronchoalveolar cell carcinoma is appropriate. But it is, again, remember, it is type of adenocarcinoma. And very rightly, the biopsy was done. The biopsy, only other two things which should be done. Why it is important? I think there was a question when there is a TB as well as a lung cancer, even if it is advanced. Now our management approach actually, in fact, has changed. If he is fortunate or the patient is fortunate, if we go further testing, say for example, in this case, it was adenocarcinoma. So we should, if we do a, the mutation testing or the PDL1 testing, and if he is lucky, it's one of the things are positive. Say for example, he is EGFR positive, although in this case he is a smoker, so unlikely his EGFR will be positive, because usually it is positive in cases of adenocarcinoma if the patient is a female and if the patient is a non-smoker. And of course, it is a South East Asian, the chances of EGFR is positive about 30% of cases. So simple tablet, you give a cheaper and simple tablet, the response will be very good. Survival will be in years. or even there are other 8 or 9 targetable genes are there. So any one of them could have been done. I'm just talking the theory part of it. Or if they are negative, if we go for a PDL1 testing, then obviously immunotherapy can be given to those patients. So my idea of telling these things is that we should not take a nihilistic approach that okay, patient has got TB, he's also having lung cancer. So anyway, he's going to die. So that thinking should not be there. He should be investigated, treated, and managed accordingly because he or she may be lucky they can survive for more years. And then the third thing, of course, the comment has already been given about the prophylaxis, the chances of TB, and the scar carcinoma. Another thing I told you, when there are scars, then the development of scar carcinoma is there. Particularly positive scars is an important risk factor for development of scar carcinoma. That is after some time that can occur, and the mechanism has already been explained to you. So I think these are in summary what I should say. We should very strictly follow, even if it is a confirmed case of TB, like this case, it was a confirmed case of TB. Sputum was positive, gene expert was positive. So to whether there is an additional disease or not, and secondly, just thinking if is not improving, it may be MDR TB or non-responding thing is not always correct. So as clinicians, we should be very, very careful. The program also must tell and teach the periphery, the dot center doctors to follow these patients more closely. These will be some of my comments, initial comments. If any other question, clarification, then I will be happy to answer. Thank you.
Thank you so much, sir. I think there are questions.
There's only one question, sir. What is the incidence of both these diseases occurrence to them?
Yeah, we see a lot of either way. I can tell you there is no such story, but these are not very, very common associations. Very strangely, had it been the scar carcinoma, as I just told you, those who have already got scars, it is not a very commonly occurring phenomena. But there are case series, case reports. But then the scars is one of the important risk factors. I can tell you they are very common, but that is possible and it occurs. I can just give it is 1 in 4,000 or 1 in 1,000 like that, because that type of study we don't have. We have got only case series reports. Nobody has really done any series like that. The only issue we can take it such type of story. Had it been so, many of the lung cancer patients, as we see, they should have got past history of TB, or those who have recovered from TB as a post TB sequelae. This is, we don't see it actually very commonly, but it is possible. I can only answer that much. I can tell you a exact figure.
Dr. Ashwani, there is a question that what was the terminal event which led to that patient? Particular to this patient only?
Yeah. Dr. Ashwini, this question is for you.
Yes, ma'am.
He said he died within 2 weeks. That is what I think he said. He died because you see, by the time he showed us the last X-ray, that is almost both sides are, both lungs are with those consolidation-like picture, the so-called bronchoalveolar cell carcinoma. And by the time actually both lungs are gone, in fact. And I don't think he is a smoker, and he was a smoker. So if they have had they done any mutation testing, maybe it was not done. Maybe that could have given some benefit.
The patient refused any further testing and any further treatment. Once you diagnosed him that you are suffering from a second pathology also of bronchogenic carcinoma, lung cancer, he refused anything, sir. He said कि okay, अब हो गया, बहुत हो गया.
Oh, yeah, sometimes they come to know that if it is cancer, they get
Sir,
frustrated
the
and
patient was very dyspneic also, no, sir. Sir, patient very dyspneic also. He was a smoker also, very dyspneic, very
now you see,
symptomatic.
Dr. Saab,
And
both lungs are full of those
and
white opacity is
I think that
considered.
there was a third comorbidity also in this patient. That was COPD also, sir. He
Hey,
was having
chalo,
that.
COPD, so nobody will die like this because he
Means
died
a lot
because of
of diseases in toto made him very much symptomatic.
no, both lungs are white. If you see,
Yes,
we
sir.
showed the last X-ray, both lungs are white. So it was quite
Underlying
advanced.
underlying airway disease भी होगा ही होगा सर उसको.
हाँ
अश्विनी
वो तो
डॉक्टर
possible है.
अश्विनी डॉक्टर अश्विनी
Yes, sir.
अब पेशेंट को बताया गया था कि उसको कैंसर हो गया है.
सर पेशेंट को बताया गया था, बिल्कुल सर. जब हम डायग्नोस कर ले उसको बताए कि जो तुम्हारा टीबी है वो पार्ट तो दवा काम कर रही है, लेकिन जो तुम्हारे लक्षण बढ़ते जा रहे हैं, जो तुम्हें आराम नहीं मिल रहा है, जो तुम्हारी सांस बढ़ती जा रही है, तुम्हें वो एक सेकंड पैथोलॉजी की वजह से है. उसको आपको कैंसर का डाउट है ये तो सर तभी बता दिया गया था जब क्या बोलते हैं वो क्या बोलते हैं कि सर जब उसको हम लोगों ने सीटी स्कैन कराया था.
किस काउंसलिंग किया था पेशेंट का काउंसलिंग.
हाँ हाँ सर, जो जितना बेस्ट पॉसिबल हमको आता था उतना हमने किया सर.
ओके ओके ओके.
Because obviously it was bilateral disease. So radiotherapy was also not possible. You could not have given radiotherapy. So the only option was chemo or the one of the immunotherapy or targeted therapy. So maybe he was.
We thought that the patient to subject the patient to genetic analysis, and if something like EGFR or ALK or ROS anything comes, we can target him. But eventually we are not able to do that.
Sir, Behra
Yes.
sir.
Yes.
So I want to ask, and just by curiosity, how
Sir.
many such patients you have seen in your clinical career?
Yes, sir. Yes, we see them off and on. But it is not a very strangely. It is not a very common thing that they have got also TB simultaneously. We have seen couple of cases, but we see so many cases of lung cancer, but associated TB is not common. It is not a very common phenomena. But sir, we have seen couple of cases, but not many. You are very right. I understand what you are trying to ask, but it is not a very common thing. But sir, they occur, but maybe they are little slightly more common. Many other cancers, not lung cancer. I am just talking about lung cancer, but other types of cancers and TB association. It is actually quite common. Overall, cancers and TB they are quite common.
Thank you, sir. Thank you.
Sir, because when we discuss such cases, there comes many policy making questions also. Like, should all the smokers to be screened in TB patients who are diagnosed with PTB should all and have smoking history, should they undergo a CCT chest at the baseline, or can be considered? And
देखिए मैडम ये about the screening, it has not yet been accepted as a method in India. It particular, although now many people are raising this question, but I think as a policy it is not been accepted because as such it is not feasible. But usual screening method is the LDCT or the low dose CT screening. The point is, it is specifically in our country, we have not yet defined which is a risky population. In abroad, in the countries like USA, they do if you are having a particular smoking index and if you belong the age of 55 to 80, then they do annual HRCT, low dose CT. And in India, we have got many non-smoking cancers. So we have to also do that if we accept that as a policy. And the second most important thing is we don't have got so many machines, we cannot afford that. And even if we detect some nodules in this country, particularly if it is tubercular or other causes of nodules like fungal infection, other infections, how are you going to investigate them? Suppose you find a small nodule in me, and I am in that age group and I am a smoker. So we get so many nodules which may be tubercular, hill tuberculosis, or many other granulomatous lesions. So how many of them we are going to, work up? Can we do the FNSC or bronchoscopy or cytopathological examinations? So taking all these things into consideration and the cost benefit ratio, at present, the India, we cannot recommend that. Although now many voices are coming, many groups are telling, we ourselves also are recommending. But I don't know. I don't think it is a feasible option at the present time. Thank you.
Sir, regarding in a case when TB is there and we have such type of X-ray which is showing whiteness, so which treatment modality regarding lung cancer is had to be done first, either radiotherapy or chemotherapy, sir?
No, but it all depends upon the stage of the disease. Say, for example, in this case, from the very beginning, I could see that hump, that in the right paratracheal region. Maybe, as I told you very clearly, maybe I am became more cleverer than after seeing knowing the case. But suppose I would have diagnosed him at that stage, so I would have staged him with the CT scan, and if it is only localized and if there is no parenchymal involvement, those nodules I should have gone for a PET CT also. Because again, PET CT issue is the diagnosis difficulty will be there. Both TB nodules as well as cancer nodules also take up PET scan. It is only the degree of positivity, the FDG take up is different, but both of them will be positive. So if I decide that it is a localized disease, then I could, and it is not operable or not surgically operable, it is only up to stage 1 or stage 2 we operate. Otherwise, radiotherapy or chemotherapy or a combination could have been done from the very beginning when the diagnosis was made.
But sir, in this case, we have a TB also and lung cancer also. So will PET scan will, I think it will not be able to differentiate both, sir.
No, that is what I told you. It will not be possible to differentiate between the two.
Yeah.
So then we have to prove that whether the lung nodules are there. It will only be a guesswork. Whether how much is the uptake, if the FDG uptake is more intense, in TB is less intense. But you are very right. It is always difficult to tell the how much is the differentiating point between the two.
Sir, Vera sir.
Yes.
Sir, I just want to ask and add both, sir. Is that to the question which has been asked by someone that every patient of smoker and TB should be screened by CT or not? What we are trying to give message is that it's not like that every patient in India could be screened by LDCT. But when you are seeing a TB patient and he's not responding to treatment, is not responding in the way which you are expecting that the patient should respond, and you have got some additional hints also, like he's a smoker, chain smoker, so you should relook the x-ray, or you should try to search out any other comorbidity present or not, which is hampering, which is not letting the patient to respond in a way which we have expected to respond. So when we saw the x-ray patient retrospectively, then we found that there is some mediastinal thing also present there here.
No, sure, that I think that is very correct, and I agree with that. Yes, we should. I agree. Rather than adding fluoroquinolone injectable, and just and then he should have done a thorough the review of the chest X-ray, because everybody, it may be misread at the very beginning. So you are very right. That should be, we should think of a other cause, even if the patient age was 47, you said. So 47, although it is a relatively young age, but beyond 40, 45, we should be careful. We should have been careful about doing that. You are very right. I agree with you. Dr. Singla, any point? Singla, sir?
Yes. Sir, first of all, I would like to thank you from the bottom of my heart. The moment we picked up this case for TB with lung cancer, we were all, I really wanted, sir, your experience of cancer lung is, we all know, need not be told here. And with a vast experience of tuberculosis also. I think, sir, you are the person who has treated both the cancers as well as the TB, the maximum in the country. So your experience is quite different, and we requested you, and I know that you have some other commitments, but still you could find time and join here. I am grateful to you, sir. So before my giving, sir, other comment. Yes, sir. Sorry. Yes, sir. Okay. So, sir, when we are talking about this case, I came across an article in the BMC 2000 Cancer 2018. There, they had mentioned that in case you have the cancer and TB, certain drugs like erlotinib, irinotecan, paclitaxel, etc., they have because of the rifampicin inducing CYP3A4. So, better to avoid rifampicin and give non-rifampicin containing regime. And so same thing happens in post-renal transplants, where these people, they insist that we want to give tacrolimus and you don't give a regime with rifampicin. Now, sir, without rifampicin, the treatment for the drug-sensitive TB patients, we have very limited experience with rifabutin. What should be the dose? What should be the duration? So in these cases, some people, I was surprised to see when I found maybe around 7-8 years back, the case of renal transplant who developed TB. And from a good aims, he was prescribed rifampicin was replaced by fluoroquinolone. So this that means HZE and moxifloxacin. And patient was responding also. So then I inquired from other places who are doing renal transplant, the good medical colleges and the other aims also. And I found the same practice is going, that they are replacing rifampicin by moxifloxacin, and the patients are responding. So this was sort of something new to me, that this kind of treatment, although I don't find any published literature on this, but the field reality, they were responding to this kind of treatment. So, sir, in cases, in your experience, once you have a lung cancer and you want to choose one of these drugs, and patient has active TB, so what is your way of treating them? Sir is muted. Sir, you're muted, please. Sir, you are muted, so we are not able to.
Yeah. Now is it okay? Yeah,
Yes.
sorry. I'm sorry. You see, fortunately for lung cancer, the drugs are not tacrolimus. It is usually the chemotherapy like which we give. Suppose the patient is to be given chemotherapy. So for chemotherapy, we have got only paclitaxel, carboplatin, or cisplatin, or pemetrexed. So none of these drugs, fortunately, have got no interaction with rifampicin. And secondly, none of these drugs, they have got also any hepatotoxicity. We have to be careful when both of them can produce hepatotoxicity. These drugs are also hepatotoxic drugs. So only thing we have to little careful, monitor the liver function very regularly and very meticulously. The other treatment, which is immunotherapy or the targeted therapy, again, fortunately, they are not very much hepatotoxic. So giving rifampicin in this type of situation is not an issue. Then your comment about rifampicin and giving, but I think there are times when the rifampicin era was not there. We are treating patients with the simple regimens. You'll remember the early days, when it was only without rifampicin regimen, also TB was getting cured. So I don't think rifampicin is the best choice, but without rifampicin, we can also treat TB, but that is possible. TB can be cured. So rifampicin is not a must. Even nowadays, whenever there is a problem, patient is not tolerating, there is a hepatotoxicity. So we don't use rifampicin. We use other drugs. So I think you will agree with that. Without rifampicin, even we can treat TB.
Yeah, thank you, sir. Actually, in this article on BMC Cancer 18, they had mentioned the name of paclitaxel also. So that was really sort of worrying me. Other drugs, okay, lotinib, etc. Now they are not the primary treatment. But
There
Patrick
is, I don't think there is a drug interaction, but only thing we should be careful about hepatotoxicity. So regular liver function test, in any case we do for any, whether when you are giving the the chemotherapy drug or even for the rifampicin, obviously we should be, when both are being used, we should be careful because they can be having additive hepatotoxicity.
Thank you so much, sir. Thank you. So now coming back to this case, like if you start from the beginning, patient had microbiologically confirmed tuberculosis. He was put on anti-TB medication, which I believe was of adequate dosage and was not responding to treatment as per the assessment of the physician. In terms of clinical response, in terms of the radiological response, rather he was deteriorating. So in this case, what was done by the treating physician was that he thought of like drug resistance and added two drugs like injection and fluoroquinolone. So again, whenever we give anti-TB medication to a person, say whether drug resistant or drug sensitive, so we have to check the dosages are correct or not, patient is taking the treatment is correct or not, and then we see whether patient is responding or not responding. These are the two basic things. And as we have discussed in the previous clinics also, if still we find that patient is not responding, and we check the microbiological test again, like in these cases, like CBNet can also be done. The rule of drug resistance, suppose it is drug sensitive, and repeatedly it is happening that non-response with drug sensitive, we have also ruled out the drug absorption. Fortunately, now in few of the centers, the TDM facilities are available, but still they are very, very few in the country as per actually which it should have been. But anyway, we should think of this also. And then
Dr. Singla, if I may be permitted to interrupt you, you see, somehow I think the program has given an relaxation to the clinician that whenever if there is an empiric drug resistance TB, so I think there is something that relaxation has now made people more relaxed and everybody first thing thinks up about, okay, it may be drug resistant TB. So
yes,
will you comment something about that?
so you are very your observation is very much true, as we are seeing now in the field also. Patient is not responding to treatment or there is a delayed response, and very quickly without looking at these factors of the dosages, the compliance, the blood levels, they switch over to the second line drugs even if it is sensitive. So that is something, as you said, sir, that is to be strongly discouraged. Like in our institute, what practice we follow is in these cases with a no response, we definitely do their drug sensitivity pattern 2 times, 3 times, and also look for the therapeutic drug monitoring. And if we find that patient is taking adequate drugs, compliance is good, the blood levels are also reduced, and it is drug sensitive repeatedly. These are the cases which may believe they are declared as clinical failure, but not too early, not at least 8, 9, 10 months of treatment. In these conditions, we may think of the clinical failure and we may start on the second line drugs, but not, as you said, sir, not, it should not be a routine phenomenon that non-response to treatment means they are clinically MDR. Actually, clinically MDR is frankly does not exist. It's a mycological term which has to prove that there is a resistance to rifampicin at least. So we need to follow this basic dictum. Otherwise, we will be over treating many of the patients which do not require it. And the role of therapeutic drug monitoring, again, I think it should be kept in mind in such cases. And so second issue is this adding this kind of 2 drugs or 3 drugs in these cases who are not showing response. So if in case we decide that patient is a clinical failure or a treatment failure, then we have to choose at least 3 to 4, some people even say 5 drugs, which patient is likely to be effective. And when we say effective means that not only microbiologically they should be drug sensitive, even drug interactions and other things, what patient has taken treatment before, it should not be repeated again. So these factors should be considered in mind when we say the 3 or 4 drugs which are likely to be effective. So we have to choose such a regime and not just add 2 drugs. And very commonly it is being seen in the field that in these cases either fluoroquinolone alone or fluoroquinolone with injection. And now we are seeing the worst thing is some people are adding even linezolid, fluoroquinolone with linezolid if they don't want to give injection because they see that this salt is being used as anti-TB. So many patients we have seen in our institute who are referred to us and they're already on linezolid or fluoroquinolone or both. So again, we'll be losing good drugs like linezolid if we have this kind of patients who are being given this kind of medication. Plus, another thing is that whenever we are treating for TB and we find there is a so-called delayed response after 2 months, 3 months, patient is not responding as it was expected. We also have to look for some superade chest infections, which could be non-tubercular pyogenes infections. Sometimes the fungal infections are also there. So before we jump out to the failures, we need to look for these infections by microbiological test. And in case they are found to be there, we need to treat them. And also we were looking for some articles whether once we have the TB and cancer together, then how much ATD to be given. Suppose patient is having diagnosed both of them together, whether to start with anti-cancer drugs or anti-TB drugs, or there should be a gap between the two. What we could I could read was that usually the people prefer to give anti-TB medication for 4 to 6 weeks and then start the anti-cancer treatment. Some even say 2 weeks. And some of the articles say that no, there is no need to do this, and they want to give both the drugs together. So, I would like to know your opinion in this context.
We give initially to start with, we give anti-TB treatment for 4 to 6 weeks, and then we start the treatment chemotherapy if it is indicated or if we decide to give chemotherapy. But if it is immunotherapy or targeted therapy, then they can be given simultaneously. No need to wait because they don't hardly any interaction.
So, sir, in this case, don't you feel that by delaying chemotherapy by 1 month or so, will it lead to some harm to the patient, or you feel?
Yes, you are very right. The by delaying, as soon the lung cancer progresses very fast. So even delaying, but then this is a very special situation. You have no other option, but we have to be little careful also. Giving both drugs, side effects, vomiting, gastrointestinal side effects, loose motion. So all these things, that also you have to take into account. And giving somebody chemotherapy and all these 3-4 drugs. So I think they are also other consideration has to be taken into account. So therefore, it usually given
like we do in HIV also. We prefer to give anti-TB first. And then with a gap of 2 weeks or 4 weeks, so same. So that means the message to us is that the common practice is first give ATT, and then after say about 4 to 6 weeks we give anti-cancer medication. So unless we are thinking of immunotherapy, in that case this may not be possible. So that is a message. Okay. And sir, also we are reading the articles that prognosis, as far as prognosis is concerned, when we have cancer and TB together, and we give proper dosages, proper medication for TB, the prognosis in terms of response to treatment, in terms of cure rate, they are same. So what has been your experience?
I agree. The response will be the same. It will be the response to. It is not going to be affected if we are treating both conditions effectively, particularly TB. So TB has to be of.
Okay, and the response to anti-cancer is also same in cases of active TB.
Lung cancer, unfortunately, the only best response comes with the immunotherapy or targeted therapy. Of course, the chemotherapy response is very erratic. We are not very sure if really it helps or not. So, but if it is IT or targeted therapy, immunotherapy or targeted therapy, the response is very good.
And so one more thing, recently, about last 2-3 years, I've started noticing, especially among the rich population, they have symptoms of fever, cough, likelihood to be TB. But as a part of list of investigations, the treating physicians get not only CT but PET scan also.
Yeah.
And as you said, sir, and worst thing is that after getting PET scan, which is likely to be positive, they start working in the direction of cancer.
You are very right. Yes.
Sir, you also come across this.
So this is unfortunately the many clinicians and physicians do that. That is not desirable, but now PET scan is included as a part of the PO investigation, which I don't think, but most of the time, unfortunately, that is a failure. But still, they advise go for a PET scan. It has got many other consideration, financial, unethical. I don't want to go into those details. You will understand that.
So, sir, again, message from you to us is that there is no need to get routine PET scan in any of the TB cases.
Yeah, no, not at all. Not at all.
So, I think we, with these, what messages, sir, I got from you, just to repeat them, that in case there is no response to HT, first we should for common things like the drug dosages, compliance, the drug absorption, before we start thinking of the MDR or drug reactions in these cases. And only when we have sufficient reasons, then only we should think of the MDR TB treatment after ruling out these things and doing the microbiological test. And also, whenever we have this TB cases not responding, and there are some shadows in the X-ray which are suggestive of malignancy, we should definitely should not take it lightly, and we should move in that direction also, as TB and cancer can coexist. Although uncommon, as sir also said, this is uncommon. And
yes, that is perfect, Professor Singla. That is the message actually.
And sir, you also told us that once these two conditions occur together, we need not worry about the prognosis. If both are treated well, then the prognosis of both the disease, cancer as well as the tuberculosis, is same if treated properly. So also,
yes.
And you also said the PET scan should not be a part of routine investigation for TB. There should be specific indications when we have to resort to PET scan. But in the list of investigations for tuberculosis, PET scan has no place in routine.
Sure. Yes, I agree. Perfectly agree.
So these are the key points which I feel from this case we learned, and from you also we learned. So I think it was a very good clinic, and fortunately you could join us. So that was the best part of the clinic today. Thank you once again. Thank you.
That is a pleasure.
Thank you, Dr. Singla. Yes, ma'am. Dr. Urvashi, ma'am.
So thank you for the wonderful discussion. Thank you so much, sir, for the guidance. I just want to add one more angle to I'm not sure if I missed it earlier because I've been in 2 other meetings. When we laid down the new strategy, we suggested to screen all vulnerables using a chest X-ray because that is the only recommended tool available to us with a high sensitivity. Now, in addition to the top 8 that we have been encouraging all the states to screen, the patients with cancer is another vulnerable group. So of course, there's a long list of several other groups. So I would be frankly of the opinion if we can actually recommend screening amongst all cancer patients, and soon we will be able to actually do this at the OPD levels as well. But for those who are here, have joined the discussion today, this may be another carry home message that they must be screened and all abnormal shadows subjected to a NAT. And this is what we have been recommending, that not to base the diagnosis of TB on the X-ray, but confirm using NAT, and all abnormal shadows should be subjected to NAT. We are not recommending that only when the X-ray says TB, we do a NAT. We are saying any abnormal shadow, we must do a NAT, because if it is something that is not picked up by X-ray as classical TB, at least the NAT will tell us if it is TB. Thank you so much.
You are perfectly right, madam. I fully agree with you. Since you are here and Professor Bharadwaj is there, I think that should be one focus in our medical college group that we should insist that the other departments, particularly the oncology departments and all other departments, whoever are handling cancer, all departments are handling cancer, diagnosing cancer, treating cancer, including radiotherapy departments, medical oncology departments, they must be induced to do this screening as you suggested. I think that should be one of our focus.
Thank you, sir, and thank you, ma'am. In fact, in Delhi government, there is right now a 45-day campaign going on for screening of NCDs, the non-communicable disease, and TB program has started with them that all during the process when they're screening the non-communicable diseases, the TB also is screened simultaneously. We are taking advantage of that and trying to screen
Thank you,
as
Dr.
many
Neeta.
as
In fact, there's a
NCDs
question in
possible.
the chat box
So
which
that
asks, should all smokers with chest symptoms undergo CECT? Of course, with Dr. Behra sir and Dr. Singla sir can guide. But all smokers should definitely undergo an X-ray, followed by TB, NAT. Of course, for regarding cancer, I request Dr. Behra sir to take the question.
Okay, madam, there is no end to it. It is a question of policy. How much we can do, how much we should do. तो करना है तो देखिए, even now there are routine screening is done. Everybody goes on for their. So if it can be done, I fully agree that so that we can catch them, whether it is COPD, whether it is cancer. Of course, cancer, the only chest X-ray has got no role, that is been abandoned. Lung cancer, I am speaking. Obviously, for TB, because there are smokers also, it is another vulnerable group as you have shown. So I think that should be done. Ideally, that should be done. If we can do it, it will be most welcome.
So, sir, in this case, like heavy smokers, say, by and large, they define as more than 40 pack years. So, you feel so that at least this group should be screened. So, I think heavy smokers, because smoking is a known risk factor for TB. So, this group should be screened definitely for TB. But you feel less than LCDC, there is no. I mean, just by doing X-ray, we are not ruling out cancer. It should be LCDC.
Doctor, that is in 70s in USA, they were doing annual screening with chest X-ray, but that was not found to be cost effective. It is not helping. So they went for the LDCT, low dose CT scanning, not the simple chest X-ray. So that method is abandoned now.
Are there any questions or comments? I think today's training was very informative and it is.
Dr. Sarith here. Can I ask a question, please?
Sure, sir.
Yeah, ma'am. In addition to smoking, isn't it that the smokeless tobacco that they should also be gutka and other things? Should we be sending them as well for bidirectional?
No, screening for what? For TB or for cancer?
सर both कैंसर के लिए तो सर मतलब वैसे हो रही है. आई एम टॉकिंग अबाउट ट्यूबरक्लोसिस. मोस्टली आई मीन जो डॉट सेंटर पे देख रहे हैं, दे जस्ट स्क्रीन फॉर स्मोकिंग एंड देन दे आस्क फॉर टीबी. बट शुडंट इट बी फॉर द स्मोकलेस टोबैको एज वेल?
डॉक्टर सिंगला और मैडम उर्वशी सिंह आंसर करेंगे.
Sir, I think logically speaking, it may not.
Okay, sir.
Logically speaking, I
don't. What is the question? Could you repeat, please?
Ma'am, question is, in addition to smoking, shouldn't the persons who are using smokeless tobacco, they should also be screened with tuberculosis once they are visiting the OPDs?
So, frankly, if you ask, let Dr. Singla complete. He had an opinion. I will give my opinion after that.
Okay.
Sir, please carry.
Okay, ma'am.
So, I think we are looking at him for reply on this question. But by logic, I think it is the smoking who should be smokers who should be screened for TB. So smokeless, I'm not sure.
Okay, sir.
Dr. Urvashi, would you like to add anything in this?
Sir, there have been instances where we have not been able to ascribe why a patient got cancer. Dr. Behra sir was narrating his experience. In my experience also, there have been patients we have lost because TB lab gave the report as positive, while the cancer was also simultaneously detected, but there were delays in diagnosing both and treatment delays, and we've lost patients like that. So, frankly, if you ask me, screening by an X-ray, which does not expose to a lot of radiation. So the new X-rays that we are now procuring, the handheld X-rays are capable of discerning normal from abnormal, and they do not cause a lot of radiation. If you permit me, I would like to go screen all my population since we are a high burden country, and any hidden or early TB, like subclinical TB, which is asymptomatic, will be picked up. At least in 94% instances, an X-ray would pick it up. So I would, like to say the vulnerable group screening strategy was the first step towards going forth and taking the screening to the population level. Since the vulnerables contribute to 80% of the TB burden in our Nikshay portal, if you look at the prevalence survey, again, the burden was almost to 80% from the vulnerable groups. We wanted to first offer the screening to these vulnerables with the sole effort of diagnosing TB early. Again, our tennis, which we designed, was also an effort towards picking early signs of TB. So the effort is to diagnose TB early, to give care to the patient who needs it, and to stop the chain of transmission. So if Dr. Sarit Sharma asked that what about the passive smoking, if you could convince, so we've had this issue of screening vulnerable using an X-ray. Some of the vulnerables do not want to get an X-ray because they feel they have no symptoms. Then the counselor has to explain to them that it could be subclinical TB, which may be asymptomatic, and since they are high risk or vulnerable, they should undergo an X-ray. If a person who is exposed to, passive smoke, say a contact of a family member of a smoker, is willing to get a screening X-ray, I do not see any harm in that. So that is my take on the topic. I'm sitting at the hem of the program. For me, it is imperative to reduce the TB burden and eliminate it. So that is my vision. And several countries have done mass level screening using X-rays. There are several examples. And possibly in a high burden setting, that would be one exercise that can be done to reduce the TB burden. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. So winding up yeah.
Ma'am, sorry, ma'am. Sorry to interrupt, ma'am. In the last, I will just I will just give one message in additional that the wrong message should not go that every spot on X-ray is TB. We've also seen patients of only lung cancer being diagnosed as TB and given at 80. We have we have seen in a tertiary care center of patients of TPE, patients of lung cancer, patients of malignant effusions, and everything. They are just any spot on X-ray and they have been started on ADT. That message should not go. It's more common is that we have got separate patients who are having cancer and we have got separate patients who are having TB.
Dr. Mishra, if I may add there, I think this is what you are here to discuss, that the two could coexist, and we must not let it go away if it is, just with one diagnosis of TB. A classical presentation of X-ray, I mean, we're honored to have Dr. Behra sir, Dr. Singla sir here to guide us more, but that is the basic pretext. If there is a doubt of a shadow appearing like a cancer, and one has a confirmed diagnosis of TB, one must rule out the cancer as well. They could coexist. That is the message we are here to share. Thank you.
Yes, ma'am. Totally agreed, ma'am. Yes, ma'am.
Can I make a comment, please, regarding the oral tobacco use?
Yes, please.
Yeah, I'm Dr. Tanmay Talukdar, and one of the audience participant raised this valid point regarding whether to screen for people who consume oral tobacco. Sir, logically, it seems that for only inhaled tobacco would hamper, the smoke would hamper the macrophage, and hence those patients would likely to develop activation of TB or even the primary infection. But in India, sir, almost all tobacco users who use oral tobacco spit all along. So imagine if they are sputum positives, they would be spitting all along. So I believe it may not be scientific, but it is logical to keep these people, this group of oral tobacco users, within the ambit of screening for active TB, especially via X-ray, as Urvashi ma'am just suggested. So if we do have a oral tobacco user coming to us, there's no harm in getting a X-ray test being done to look out for TB. Over to you, sir.
Sir, regarding, sorry to interrupt, sir. Sir, regarding this question, sir, we are having a patient who was using tobacco and 3 years back. He was diagnosed with buccal mucosa cancer in Gorakhpur only. And this patient had a radiotherapy and chemotherapy of palixitil and cisplatinum. And now again he developed tuberculosis. So now he was RR. So we have started the regimen and patient is on treatment. So you are right that such patients should be screened for patient is of oral tobacco. But we have to also take the history whether the oral tobacco user was, say, this patient was taking 10 pouches per day for last 10 years. That's why his mouth was not able to open 3 finger. It came to 2 finger and now 1 finger is opening after radiotherapy and chemotherapy. So you're right that such patients should also come in vulnerable population and they're also being screened. Thank you.
Thank you, sir. Thank you, everyone, for such an active participation. So a lot has been discussed today, and we have, discussed how much screening is important. So we should try to screen the patients for tuberculosis as far as possible, and also for the DTOs and the field staff that we have here. The importance of follow-up has come up very well, like Dr. Behra sir said, that we really need to follow the patients clinically, microbiologically, and radiologically throughout. Anytime where we see that the patient is dipping, we should do the investigation. So that were the 2 carry-home messages, screening and follow-up. So with this, we come to the end of this clinic. I would request Dr. Bharadwaj sir to propose vote of thanks.
Thank you, madam. Thank you, Neetaji. So it was a wonderful discussion, quite helpful, informative, and excellent. The views expressed by Dr. Behra, so I consider him the best national expert in lung cancer. So thank you, sir. Thank you. Then thank you, Rishi. I consider him not an administrator, but an academician. So wonderful view, the expert view from your side. Then Dr. Ashwini, wonderful case. So I missed AIMS, Gorakhpur. I never came there. So I suppose in this winter I will visit that institute. So then, of course, the person in the whole of the country, Dr. Rupak Singla, your expert meant they always matter to me, information and excellent comments to me. So my take up on this is I also agree with Dr. Urvashi Singh, DDG madam, that we should not lose any opportunity to screen for tuberculosis wherever, whatever may be the conditions. We should not lose any opportunity. So thank you very much. Thank you, Neetaji, for giving me a chance for NTF to take part in this National Difficult to Treat Clinic, TB Clinic, which is being held regularly. Today, attendance is short, as you initially told that today is Ganesh Chaturthi, so people have not joined because in Gujarat as well as in Maharashtra it is celebrated. So I see, but I have one complaint regarding Uttar Pradesh. I specifically sent message to each person under state task force to join. So the attendance from Uttar Pradesh is not to my expectation. So thank you very much. Thank you, madam.
Thank you, sir. Thank you very much. But we had, sir, 250 spokes, which is quite a good number in spite of being a festival. So we thank all the participants who joined us. And thank you all the experts and Dr. Behra sir, Dr. Bharadwaj sir, Urvashi ma'am, Dr. Rishi, Dr. Ashwini. Thank you, everyone. Thanks a lot.